It is indeed an honor to see all your wonderful faces around the world. And disclosures, I have a few of them here. I think my biggest disclosure is I have an absolute passion for patient blood management. And that passion has at times gotten me into trouble. Shannon can tell you that recently I tried to get myself into more trouble by thinking about publishing a group of editorials in major newspapers around the world to bring to light what I think is this travesty, which is that medicine doesn't really understand what they're doing in terms of blood transfusion, utilization of red cells, utilization of blood products, and that I am convinced all the science in the world won't change how people view this. I think what will change how people view this is for us to go to the public. The public needs to understand that things are not going correctly. So I think Shannon brought up that religion versus transfusion, and this slide may be a little bit busy because of all the red cells behind it, but it's meant to provoke you for some feelings and thoughts. And I think I may be the one who actually coined these terms. But if you look at religion on the left-hand side, it's a belief in an unprovable series of teachings. And the teachings from foundation for how the believer approaches life, medicine, in many situations, they form that foundation. And there's multiple amounts of dogma taught by the people who believe in the religion. And there's a resistance to questioning the dogma. And the choir sings, and they get up and they flap their hands and they run around and they sing some more when something supports the religion. But when something doesn't support their dogma, it's discarded. And those who don't support the dogma are fought, and they're marginalized, and they're destroyed, or in the 1300s, they were burned at the stake. So medically, you can be burned at the stake by daring to stand up in the face of what the dogma is. And attacking the dogma is taken as hearsay. So what about transfusion? There's no or limited level 1 evidence. And I can't thank Shannon enough for showing exactly that. There is little or no level 1 evidence to show that transfusion does anything other than make people worse. In his overview slide there, he showed exactly that. And he showed that when you get to lower and lower levels of hemoglobin, it does either nothing or potentially make things worse. I think we can actually do a randomized controlled trial to show whether transfusion works or not. But it has to be a randomized controlled trial against the best of patient blood management. And how can you do that? I've actually designed how to do that. Unfortunately, I've yet to convince the United States National Institutes of Health that they should fund such a thing, because that is against the dogma. And so there are no randomized controlled trials showing improved morbidity and mortality. None, zero, none. Nothing that says that it does any good. And a belief that blood is good and that stored blood in circulating red cells makes you better is exactly that. It is a belief. It's a belief that give a unit save 4 lives. That is the public relations campaign in the United States that's on the evening news. It's in our magazines, and it's completely, utterly false. There's no evidence that by giving 1 unit of blood, you save anybody, let alone saving 4 lives for every unit of blood given. But that's what the lay public has been driven to believe by an industry that continues to publish that, a falsehood to all of mankind. And so to discredit that evidence and to fight against it, as I have done, has at times bitten me very hard because I dared to stand up. And both Aryeh Shander, who I love very dearly, almost as a brother, and I have been discussed as the fringe element. We are the fringe in medicine. We are not accepted as what should be right. So it's interesting that there are many similar sound bites, and Aryeh actually has done a wonderful discussion of this, that if you go and look at the writings from the 1400s all the way until the late 1850s, 1860s, about actually bleeding and lancing patients to bleed them, you can find almost the exact same words verbatim compared to the literature that's out there in modern day transfusion, published in JAMA and other places. So isn't it absolutely amazing? So we're now in the COVID epidemic. COVID is overwhelming my country. I won't get into the politics. We had a as yet uncompleted election last night. I stayed up a little late, and I'm a little personally disconcerted that it's not done. But COVID is exploding in the United States, and it's exploding around the world. Somehow, with some piece of luck, sub-Saharan Africa seems to have escaped the disaster that we're having in our country. But in my usual way, I try to be outspoken regarding the blood transfusion industry, and wrote a editorial which was summarily rejected because I dared to suggest that COVID might get into the blood supply. And indeed, in China, and indeed in South Korea, they have isolated it from their blood supply. And indeed, in the United States, we refuse to even look for it. Yet, we take the public expression that because SARS never made it into the blood supply, COVID can't possibly make it into the blood supply. Well, how does COVID get to the brain? How does COVID get to the heart? How does COVID get to other organs if it isn't through the blood supply? So there are a number of questions that are out there. And if there was ever a time that we need the world to come around and embrace what's been done in Western Australia and to follow their example, it is now. And so Aryeh Shander, and I'll honor him with this, he led this paper, but you can see many of our names on here behind it saying, yes, we need this. And it's kind of sad to me that to date, as this was published in Anesthesia and Analgesia just recently, this is not being picked up by every news group around the world. So what I'm actually doing in relationship to what the Nobel Prize winners that were brought up by Innocent has to do with COVID. So what the Nobel Prize winners have pointed out to us is how every one of our cells instantaneously, continuously, and in milliseconds measures oxygen tension, partial pressure of oxygen. It doesn't measure the amount of oxygen carried on hemoglobin. It doesn't measure the total amount of oxygen in your hemoglobin bloodstream. But HIF1 alpha, which is a specific enzyme, an iron-based protein, actually senses in real time oxygen levels and signals those cells to do various different very cool things. I could give an entire lecture on that. But when that data came out, it was absolutely crucial to me because I've spent my whole life trying to understand oxygen supply, demand, delivery, and this was the final key, was how does a cell sense it? But I'll get to more about that in a few minutes. So there are a few areas of medicine with less science than the use of blood. So what's art and what's science? What's religion? And, we'll get to some of the art of actually how you take care of patients who've got very low levels of hemoglobin. But let's talk about what's lacking in terms of science. So as Shannon Farmer said, evidence-based medicine is based on these Bradford Hill criteria and such. And yeah, smoking has been proven without randomized controlled trials. So as Aryeh Shander and other people say, if there's enough evidence that's retrospective, that's associations, you can go to Bradford Hill And it absolutely has been shown to be cause and effect. So cause and effect, there's more than 7,000 articles looking at transfusion retrospectively and adverse outcomes. Is that cause and effect? Or is it a continuous belief that if those retrospective studies had only found one more potential confounder, they would have discovered why their study was wrong? And that's the state of the art we are. Dogma, don't you dare attack the dogma. So there's never been a randomized controlled trial showing transfusion is efficacious, and blood transfusion has never undergone US, European regulatory, or any other country's regulatory efficacy and risk adverse event outcome research. I am presently embroiled with a battle with the FDA about getting a treatment for COVID based upon the HIF-1 alpha understanding that, that was brought up by Innocent. And it's to use inhaled adenosine. Inhaled adenosine is highly effective, and it was just published by a group of people in Italy, and it's highly effective in attacking COVID and in reducing the inflammation in the lungs. But the US FDA and I are fighting about whether we can do that or not. So the vast majority of studies have outlined risks of transfusion, very few about benefit, and there are assumptions made all over, and guidelines exist all over again. So who makes guidelines? Gray-haired old men like me make guidelines. So you get a bunch of gray-haired old men like me, and some ladies with blonde hair because they get to dye their hair. But mostly you get a bunch of very astute people. You put them into a room and say, "What do you think? What do you think? What do you think?" And then you get groupthink starting, and groupthink drives them all to say, "Well, here's when we ought to transfuse." And the opinion has changed. So where did we get some of these transfusion guidelines from? They're certainly not science. Let me tell you where 10 grams per deciliter came from. 10 grams per deciliter transfusion and or a loss of 20% of circulating blood volume was what I was taught and what I was forced to transfuse when I was at the Mayo Clinic, and I was that resident. I was their special resident up there. So where did that come from? It came from the Mayo Clinic. What we used to call, this wonderful place in Minnesota that is a bastion of surgery and development of medicine. But so there was a anesthesiologist who in the 1930s to 1940s kept track of all the surgeries and when surgeons would transfuse. And so when he looked at 10 years worth of data, one single number stood out at him, 10 grams per deciliter. And because surgeons were gods back in those days, and I know Nathaniel's a god, so he published that that 10 grams per deciliter was the proper place to transfuse patients. There was no bench science behind it, and it was reprinted in every textbook of anesthesia and surgery until 1987 when the AIDS epidemic hit. So that was the guideline. Now it's at 7 grams per deciliter, and that is completely arbitrary. And why has it gone down to 7 grams per deciliter? It's perhaps a slight genuflection to the literature that Shannon, Aryeh, myself, Waters, so many others have published saying there are these adverse outcomes. Axel Hoffman. I mean, it goes on and on and on. And so it's a slight genuflection to that, but it's a basic misunderstanding. It's a complete and basic misunderstanding that medicine does not understand what hemoglobin does and what oxygen delivery is all about. We have come to worship hemoglobin and worship that you need this particular level of hemoglobin for your patient to do well. but as you've seen, there's no science beside it. And transfusion of older cells are worse. They either reduce oxygen delivery to tissues or they do nothing. Now, once again, somebody's tried to undertake randomized controlled trials to prove that that is wrong. There are about 175 different articles carried out in laboratory medicine that show that when we use older cells, the animals do worse and they have worse oxygen delivery. But yet, the blood bankers have taken it to randomized controlled trials, and the randomized controlled trials have shown no difference in outcome, old versus fresh cells. But they're underpowered, and they're not done based on the science that came out of the animal work. So it is, again, accepting the dogma the way you want it and designing the studies the way you want it. So why do we transfuse? We transfuse, and this was what, I used to tell my mother when I was 3 years old or 4 years old, why are you doing what you're doing? And the answer was because. Well, because isn't a very good answer. And so we're now in that state. And when must we transfuse? And that's still unknown. Shannon showed some patients with very low hemoglobins. There was a question from the audience about a neonate with a very low hemoglobin. Do we know when to actually transfuse? And there's no monitor that tells us that it will be better. So here's data that I like to show, and this is from heart surgery in the Western United States at Providence Health Center. So there's 11 or 12 different surgical centers across the western half of the United States, what's called the Intermountain West. Hospital A is in Los Angeles. Hospital A is in Everett, Washington, where Trudy Gallagher was from, and has a really profound and wonderful patient blood management system. Hospital L is in Los Angeles. And so the CEO of this group of hospitals brought everybody together, all the cardiac surgeons, 4,000 people together to say, somebody here is doing something wrong. And you guys are costing me a lot of money. And I want to know who's got the best patient outcomes and who doesn't. The individual bars there are the transfusion behaviors of individual surgeons. So you'll see that there's a belief system at Hospital L that's profoundly different than the belief system at Hospital A and B. You know who has the best outcome? Hospital A and B. You know who has the worst outcome? Hospital K and L. Is that because of their transfusion behavior, or is it because they all have multiple other protocolized ways to be very patient-centered? I can't prove that as a scientist, but boy, it's tempting to like my dogma versus their dogma. And so really fascinating work. So what's the culture of transfusion in each different place? Clearly, the culture of transfusion in Western Australia is profoundly different than it is in my center. And I can tell you, I had a meeting yesterday to develop a business plan for our institution to try to emulate what Shannon and Simon Towler and others have done in Western Australia. It didn't go so well. I am still pushing the rock up the damned hill, and the rock keeps rolling over me. So I'm going to read you a poem. When is the last time a luminary has decided to just read you a poem? But we're going to read through this because this resonates for me over and over again about science versus not. One day through the primeval wood, a calf walked home as good calves should, but made a trail all bent askew, a crooked trail as all calves do. Since then, 300 years have fled, and I infer the calf is dead, but still he left behind his trail, and thereby hangs my moral tale. The trail was taken up next day by a lone dog that passed that way. He then, a wise bellwether sheep, pursued the trail o'er vale and steep, and drew the flock behind him too, as good well-wethers always do. And from that day o'er hill and glade, through those wood old paths was made, and many men wound in and out, and dodged and turned and bent about, and uttered words of righteous wrath, because 'twas such a crooked path, but still they followed, do not laugh, the first migrations of that calf. And through this winding wood away stalked, because he wobbled when he walked. This forest path became a lane that bent and turned again. This crooked lane became a road, where many a poor horse with his load toiled on beneath the burning sun and traveled some 3 miles in one. And thus a century and a half they trod the footsteps of that calf. Okay, I'll leave the rest, but you get that by following the ass of the person in front of you or the history of everybody else, doing what your gray-haired old men told you to do, like I was told at the Mayo Clinic, and we genuflected in front of and never asked the question. We wear the path deeper and deeper until it becomes the road that everybody follows. So where do we go wrong? We go wrong at the very, very basics of concept, which is that hemoglobin was put on this earth for us to utilize in a blood bag to give to a patient. It comes from the very basic misunderstanding of how oxygen gets from my nose to my lungs, through my heart to my tissues, and what that oxygen means to my tissues. And that's a subject I've spent 41 years studying, is the critical oxygen delivery to tissues. And I'll put it to you that if you transfuse and you do not understand how hemoglobin works, how can you make a rational decision? So hemoglobin evolved on the Earth's surface by cyanobacteria, blue-green algae. They evolved on Earth by blue-green algae who are all obligate anaerobes. It evolved to detoxify oxygen. Oxygen is a profound toxin, but for us who are aerobes, oxygen is needed in just the right concentration to perform the electron transfer reactions to give us energy. But we've also evolved to live in a very narrow band of oxygen, both concentration and supply. So your cells are supplied with oxygen continuously in a just-in-time FedEx, DHL, whatever your fast delivery service is. Every cell is designed to get just enough oxygen, and too much oxygen is toxic. Where do I get this from? Well, hemoglobin combines with oxygen 5,000 to 100,000 times greater than it breaks away. So really the basic physiology of hemoglobin is to suck up oxygen. And I can't tell you how many students, residents, other doctors have said to me, well, then why do we have 14 or 140 grams per liter of hemoglobin if really it's there to, didn't we evolve the 14 grams or 140 to supply oxygen to our tissues? And my comment is, well, you need to know what the critical amount of oxygen or the critical amount of hemoglobin is at which tissues can no longer perform their activity. And I will guarantee you that most of us in this audience don't know that number. And it's consistent. And it doesn't matter whether you're a rat, a mouse, an elephant, a pig, or a human being. It's exactly the same number. And it's around 2.5 to 3.5 grams per deciliter. And you don't die at that level. What you do is you shift from aerobic to anaerobic metabolism. And that's probably the absolute basement level of which you need basically enough hemoglobin at that level to supply the minimum amount of oxygen. So everything else in hemoglobin, all the other hemoglobin we have, is there to serve one function, and that's to buffer excess oxygen. So if you understand that concept, you flip all of medicine's assumptions about transfusion on their head. And so that allows you to have an art. That allows you to truly understand the physiology of what you're trying to treat. But we don't teach that. Nobody teaches that one basic function in any medical school I know of anywhere in the country. And I've challenged our dean of our medical school to say, show me your course on the transfusion decision. Well, we don't have one. Okay, well, that's the single largest decision that anybody makes in medicine today, is when to transfuse and when not to transfuse. It's the most overutilized technique, and you don't have even a lecture on that? No, we don't. Okay, well, I don't know of any medical school that does. So this is a study we did back in the early 2000s, looking at a rat model of critical oxygen delivery, and you see down there in that left-hand corner where we hit DO2 crit. So DO2 crit is the actual cellular oxygen delivery at which point your tissue begins to make lactic acid and to dysregulate its cytochrome system. And so if you maintain the animal normal in every other way, you won't start to see that until you're down below 3.5 grams per deciliter and down to a very low hematocrit. So that possibly explains why there's all this literature that giving transfusion doesn't make a difference. Because unless you're at DO2 crit or hematocrit, at which the critical oxygen delivery could make a difference, then giving extra hemoglobin won't improve the outcome. And this is a study that I think ought to be a sentinel article for everybody in medicine, or for everybody who's going to transfuse in medicine. And what they did, this is Amy Tsai's lab and Taglietta's lab and other people who have looked at transfusion of old versus fresh blood. And what they found was that if you use old blood, in other words, aged like we age it in the blood bank, and you give it to rats that have a low, this one's actually about cardiac surgery, but the one I'm talking about is actually done in a rat model. And in a rat model, if you take old blood, aged the way it is in the blood bank, and you give it to rats who are who have a relatively low hemoglobin and hematocrit, you will improve their mixed venous oxygen saturation, and you'll improve their CVP, and you'll improve all the things you and I measure in medicine, but you will decrease oxygen content by 400% in the cells. And this one here I'm showing is actually in humans and showed no difference in oxygen delivery. So when Shannon shows that there's no increase or there's no change in mortality where we go to lower and lower hemoglobins, there's no efficacy of transfusion. That's because we're not transfusing at a point where people are critical. And so we're doing a therapy to try to prevent people from getting to a critical level. So we're trying to avoid getting to that. So why do we still believe in all these falsehoods? Here's transcutaneous oxygen tension, critically ill patients. Oxygen delivery went up, but oxygen consumption was unchanged. So oxygen delivery is a calculated number. It's not tissue oxygen, it's a calculated number that you and I calculate based on hematocrit. And so it's again something that we have made up. So 75 million units transfused, and we have no indication when to transfuse, nor the outcome data to support it, yet it keeps getting supported over and over and over again. And it does bring up the question, why are we doing this? And these guys actually looked at what happens when you approach that DO2 crit. And so maybe the only place to actually study this is to study patients who are at DO2 crit. Now, here's the bad news, is that if you take somebody who's critically ill and take them to 2.5 to 3 grams per deciliter, and then transfuse them, and we did this in a rat model that in my laboratory, if you then transfuse them, you make DO2 crit higher. What do I mean by that? What I mean by that is that if you then use banked blood in those animals and you've taken them to the critical hemoglobin level, the point at which they deoxygenate their tissues gets worse. It goes higher. It means shock comes earlier. DO2 crit is actually the definition of shock. So it's the shock is where you shift from aerobic to anaerobic metabolism. And if you give bank blood, you make shock come earlier. Noodle on that for a minute. Think about it. If you give banked blood, which doesn't deliver oxygen, and you have a measured higher level of hemoglobin, the hemoglobin at which you absolutely shift from aerobic to anaerobic metabolism is actually higher because the hemoglobin you're giving functions worse. So shock comes earlier the more blood you give. Wow, that's absolutely upside down from what we teach everybody. So read Aryeh Shander, and I give him such great praise in the world. This is something I wish every one of my med students, residents would read. What's really dangerous, anemia or transfusion? And we're spending lots and lots of time talking about anemia and trying to eradicate anemia. Eradicating anemia is extremely important because that means that you have your own circulating blood. Eradicating anemia by transfusion is absolutely the wrong thing to do, and it's based upon assumptions. So let me make two comments about how I got started in this question about transfusion. And I've met Denton Cooley, and I've actually talked to him about his bloodless surgery and stuff. But back in the 1990s, early to mid 1990s, I took part in a large group that studied outcomes in heart surgery. And I asked a very basic question: do we know what is the best hemoglobin hematocrit to send patients to the ICU? We've got these guidelines. What and at that time the guidelines said 8 or 9 or whatever. It was higher than it is presently. And lo and behold, to my surprise, it came out that those patients who had higher hematocrits that went into the ICU did worse. And what it translated out to was that those who were transfused did worse. And I was one of the first to publish on that. And it triggered a lot of people in cardiac surgery to say, do we really know what we're doing? So if we keep doing the same thing, and I'm glad Shannon showed Einstein, if we keep doing the same thing over and over again, following that calf path, that is the definition of insanity. If you're trying to do the exact same thing and expect a different outcome, you're not getting anywhere. You're just walking the calf path. So the World Health Organization is totally on board. This society is totally on board. SABM's totally on board. We understand that it makes a difference to decrease transfusion. I give lectures fairly often about the emerging world, and unfortunately, I am impressed by the remaining colonialism of Western Europe and North America, and the colonialism has taken the form of trying to impose Western blood transfusion or the North American and European view of blood transfusion upon sub-Saharan Africa. The motivations and the abilities and stuff in sub-Saharan Africa to do all the NAT testing and to reduce the risks of infectious disease is nearly impossible. So the more effort you folks put into bloodless medicine, the more your patients will benefit. Just exactly the way it was in Western Australia, although they've done it with very modern blood transfusion available to them. So there's a lot of international motivation for trying to do this. So what are the most common human errors in medicine? Well, lo and behold, these are the most common. Blood transfusion, unnecessary therapy, which blood transfusion is number one, is probably the third largest error in medicine. So blood transfusion is the third largest error in medicine. And it goes to us promulgating the same thing over and over and over again. 40 to 60%, I've read some people say 78% of transfusions are unnecessary. And we don't teach anywhere why patients are transfused. So PBM is the epitome of a quality assurance, quality initiative, cost saving thing. And Shannon was right on the money. In the United States, less than 30% of US hospitals do PBM. And yeah, these papers that say, if you're not doing it, it's substandard care. But Aryeh Shander, myself, a number of other people went to the Joint Commission who actually regulates hospitals in the United States a number of years ago and tried to get it that patient blood management had to be a part of that regulation. And we were opposed both by the American Association of Blood Bankers and the American Red Cross. And it was thrown out for political reasons that they wouldn't institute it. So the world has pockets of shining success, and I'll focus on Western Australia. Ontario and Canada is another one. Probably what you all are doing in Nigeria is another great shining success. When I was in Virginia, we had shining success in heart surgery. Countries are going towards this, but the progress is slow and resistance is everywhere. Try to attack somebody's religion. You ever want to feel resistance and hatred back at you, it's to attack somebody's religion. And if transfusion is a religion and you attack it, you will be met with resistance. So your operation in the blood is the best blood. That's what I want. Any number of surgical meetings, anesthesia meetings, I stand up and I'm asked to talk about blood transfusion or patient blood management. My first question to the audience is, who here wants a blood transfusion? Raise your hand. There's not a single hand that goes up. Who here doesn't want a blood transfusion? 100% of hands go up. And then I say to the surgeons, are you guys all hypocrites? Because you clearly give everybody blood transfusions. And you want your patients to have something that you don't want. So why aren't you embracing what, has been shown by science to be really the best of everything? This is my Bible and text that I use in our institution. Shannon's got lots of good stuff out. Shannon's trying to put out a great book for the lay public right now. And I think taking this to the lay public is going to be our future. We all know the three pillars. I will say that, transfusion is a therapy in search of a disease. That is that's a quote from Aryeh. Anemia is bad and it's linked to adverse outcomes, but it's linked to adverse outcomes because of the behavior of physicians. It's not in itself bad until you get to below those critical levels. And treatment with anemia makes outcomes worse, not better. But the assumption has always been that take them to surgery, they're anemic. If I need to, I'll give them a couple units of blood. That's the fall down, and that's the problem. And it goes back to not really understanding how oxygen is delivered. This is a classic slide about adverse outcomes with anemia, all these different diseases. Yeah, every one of these diseases is made worse by anemia. But if you transfuse, you make them all worse rather than better. So we've just begun to believe that. And the new paradigm is anemia is an independent risk for morbidity and mortality, regardless of the level of hemoglobin, but it's an independent risk. It's an independent risk because of the physician's behavior and the lack of understanding. It's not necessarily purely an independent risk. Anemia may absolutely be a biomarker for a complex set of inflammatory reactions, which are the end stage of multiple disease processes. So just like that question came about, I got a neonate with a hemoglobin of 2 or 2.5, and it's in congestive heart failure. What do I do? Well, my first thought was, if you're going to give that neonate red cells, you're now going to put them into worse congestive heart failure because you're going to overload the heart. We don't know whether that heart is failing because of lack of oxygen delivery or not. We just have made that assumption because we're in such a hemoglobin-centric world. We need to understand in depth the complexity and the beauty. So anemia is bad, transfusion is worse, and this is a great article by Lepar and a group in Virginia where they looked exactly at that for heart surgery. And the two are highly interrelated. But very few people are taking a look at the human behavior and what drives the human behavior that's making the decision of the paternalistic anesthesiologists and surgeons and critical care doctors that continue to follow this behavior. So I'm starting to run a little bit over time. I want to make sure we got questions. Let me just say that, let me go to the Jehovah's Witness data at the very end here. So what if blood is not an option and the patient refuses transfusion? Patients with severe antibody activities, military situations, natural disasters, emerging countries, austere places, they need to have the ability for us to do these kinds of things where we avoid transfusion and we can actually get by without using any blood. And if you look again from groups in Australia and New Zealand, when they looked at their behavior with Jehovah's Witnesses, they found that their patients did really quite well. Others say that mortality rises sharply if there's hemodynamic instability with hemoglobin less than 5 to 7 grams per deciliter. I've not found that. I've found that you can go to profoundly low levels. Here are 2 articles that I wrote an editorial about out of Japan, I believe, wherein patients went to 0.6 grams per deciliter and another one 3.3 grams per deciliter. They all survived. I have had a personal group of patients that I've never had anybody die on me from low hemoglobin. And that's where the art of the medicine comes in, is to understand the effects of oxygen delivery with and without extremely low levels of hemoglobin. So this is one from a Cleveland clinic I particularly like, wherein they've shown age match, sex match, severity of disease match patients. Those patients who got routine doctor care did far worse than those who were forced to not get a transfusion. Is that a randomized controlled trial? No, not yet, but I think one can design one if we wanted to. And that is a profound difference. And it makes one think in depth about the art of how you handle patients like this. I've had 3 patients with lower than 2.5 grams per deciliter, 1 patient at 1.2. They all survived. We have to both teach from the top down, from our administrative suites and from our bottom up. And that's where I love what's been done in Western Australia. And I think we need a basic understanding of hemoglobin and how oxygen is delivered to tissues, which we just don't have right now. And I can't expect everybody to have spent 40 years studying critical oxygen delivery the way I have. But it brings to question, the assumptions that are made over and over and over again. Thanks everybody for giving me the chance to present to you.